Thank you very much. Well, those of you who've been keeping an eye on the agenda realise that we've moved things around a little bit. So we're going to crack straight on with our next session today. I'm just going to invite to the stage the rest of the team here now and hand over to Nelsie.
Thank you. Hello, I'm Nelsie. My pronouns are they, them, and I'm a service coordinator for Primary Care Sheffield's Primary Care at Scale team, but I'm here today in my capacity as one of our EDI champions, that's Equality, Diversity and Inclusion. And today's session has been put together by healthcare professionals with a mix of lived experience and specialist knowledge. We're joined here today by Dr. Otto Willen, who is a clinical research fellow and an SHO discussing the current situation for transgender healthcare in the UK, including both research and lived experience, and Dr. Hannah Prosser, who is Director of Uni Health Service and Lead GP for transgender patients. I'm going to start with a couple of definitions for us. So essentially, when we talk about transgender people, it's important we get the terminology right. When we say a trans man or a transgender man, that is someone who was assigned female at birth and is a man. When we say a transgender woman, that's someone who was assigned male at birth and lives as a woman. And when we say non-binary, hello, that includes me, someone who could have been assigned male or female at birth and whose gender identity doesn't fall into either binary category. Some of them may or may not use they, them pronouns and may or may not seek medical transition as well. This session aims to empower providers with the knowledge to provide the best possible care for trans and non-binary patients who are a really underserved group, and it's hoping to help us all to better understand their healthcare needs. There will be time for questions and discussion at the end. I just want to say that today's session won't be a space for debating whether trans people have a right to exist or to access healthcare. And with my EDI hat on, I want to remind everyone that the protected characteristic of gender reassignment has the right to be free of harassment, indignity and hostility under the Equality Act, but we also acknowledge and uphold the right of everyone to hold personal beliefs, whatever those may be. So hopefully today will be a really positive space for us to learn together about how to provide the best possible care for our trans and non-binary patients. And at the end of this session, there will also be a transgender healthcare resource pack that will be circulated that's got links to loads of brilliant resources. So in the future, if you ever need to come back to that, that will be circulated. So without further ado, I'll hand over to Otto.
Great. Hello, thank you Nancy and Tom for the introductions. So today we're going to be a little bit of a whistle stop because obviously this is a huge topic, but we'll try and cover what we're covering is based on some work that we've done asking the Sheffield trans community what they want their GPs to know, how they feel their care is affected. And so that's given us this, that hormones and bridging are a priority for us in the community. But admin supporting letters, it's all helpful. We also asked yourselves in our pre-survey, thank you so much for filling that in, and that's guided how we structure the session today. So we'll be talking a little bit about background, about the context of the current situation in the UK, why we're even here talking about it. We'll talk about admin considerations for primary care. I will do my best. Apologies, I'm not a GP, so Hannah will be really helpful with that and navigating those systems. Talking about the current healthcare systems, hormone prescriptions, and then Hannah's going to give some really great help on her practice. And as Nelsie mentioned, there'll be a Q&A at the end, so if you can hold questions till then, we'll do our best. So, why are we here? I think it's important to acknowledge that potentially a lot of people feel like trans people are a tiny minority who are frequently discussed, and maybe people are bored about hearing about this. In 2021 census data, trans people made up 0.5% of the national population. In Yorkshire and the Humber, it was half that, so 0.25%. Tried to find a comparable diagnosis. What I came up with was chronic Hep B. So something that we should have heard of and should know how to deal with, but it's not a majority of our patients. However, the reason that it's so important is that the healthcare system in the UK for trans patients, specifically for gender affirming care, is functioning increasingly poorly, and that's due to chronic underfunding, which we all deal with, I know, primary and secondary care, and mental health services. And as we know, mental health services generally, but gender-specific services are particularly impacted that. This has led to a situation where, for example, the quoted Porterbrook waiting list at the moment is 64 months. That figure comes from the fact they are currently seeing patients referred in October 2020. National work's been done through Freedom of Information requests to work out if you're referred today to a gender clinic, when will you be seen for your first assessment? We're lucky in Sheffield that that's 10 years. The longest wait list in England is 31 years, based on when patients are referred, how many on the list, and what rate people are being seen. And unfortunately, this has led to a situation where services in the UK do need attention and reform, which I'm not asking you guys to do, don't worry. And however, that reform and attention is coming at a time when there is a hostile political situation. I'm trying to sound not too much like a conspiracy theorist as I go into this section, but there have been major healthcare reviews, and it is a known fact that the people conducting those reviews did have meetings with political ministers before them, and the reviews that have come out have been not received well amongst international communities. So there is increasing restrictions on healthcare access, which is actively creating health inequalities nationally and locally. We'll come on to that in more detail later. And this has also led to a situation where I think a lot of people feel that trans healthcare is very niche, very specialist, and that we don't feel, as healthcare professionals, confident in managing trans patients. So I'm not going to go through all of this text, but this is a survey that a major UK charity carried out of healthcare professionals. Obviously, you've got to take into account sampling bias, so people who responded to the survey probably more invested than others. But in that group, a lack of confidence was felt by most respondents. Less than half felt comfortable in ability to support trans patients, and less than a third of respondents felt that they received sufficient training in these topics. And our pre-survey showed similar things. So whilst comfort levels are shown in different colours here, so not confident at all is in green, and for many of the different topics, that's quite a major colour. So we're here to try and help. And why am I talking to you about this? So I've got a medical background. I graduated 4 years ago now. I currently work as a clinical research fellow in infection and immunity, but I'm here today because I've got a nice intersection of being both medically trained and also a trans person myself. So to tell you about my story is an illustration of care in the UK. Before this even happened, I had to realise I was trans. That happened in 2020, whilst I was intercalating, whilst I had a bit of time and space. So it happened when I was older, which may not be common in the media. I think we hear a lot about kids that always grow up knowing that they're trans, and from the age of 5 they're wanting to express themselves. Conversations I've had with both professionals who've seen me medically and also my community, that's not that common. You have to know about something to understand your experiences. I thought it was normal that for the first 22 years of my life, I just didn't recognise the person in the mirror. I just thought that no one really connected with seeing someone there. And then I learned more, and that helped that realisation. So once I realised that, I began the process of what we call social transition. That's looking at new names, trying some different ones on, telling my family, friends, and university at the time that I am trans. This photo is just after I got my first ever haircut. All of that process. Following that then led into the process of legally transitioning. So once I felt I'm confident, I know what I'm doing, I then began the process of legally changing my name with a deed poll, talking to my GP, and changing the gender marker on all of my documents. With these bits of evidence, I was then able, very luckily, to access a private psych evaluation. These requirements are slightly changing, but at the time I had this, I needed to submit all that legal evidence to get a psychiatric diagnosis of gender dysphoria. And once I did that, I was able to access hormone therapy. I was lucky enough to have shared care with a GP, so I paid for my endocrine, I paid for my assessments, I paid for my endocrinologist, but luckily my bloods and my prescriptions were aided by my GP. Following a second psychiatric evaluation, I then, a couple of weeks after final, had surgery, which then meant I was able to start F1 and start my professional life presenting fairly male, not having to explain myself all of the time. And that's a really, I think, lucky story of healthcare in the UK. Further on from that side, I have had in recent months my very first assessment with Porterbrook, who are our local gender services. They then are going to repeat all of these evaluations to confirm the diagnosis and move me on to NHS care, at which point I will be able to, with all respect to my private endocrinologist, stop paying him every year. And what I found interesting when looking into this is these psychiatric evaluations are, and the recommendations for such as living for 12 months in your assigned gender, are not evidence-based, but based on expert recommendations. So the first sort of practical point we're going to talk about is that social and legal transition and admin, because I think that can be quite overwhelming and create confusion about how do you interact with IT systems and NHS numbers. So the first thing to note is that with a transgender patient, their pronouns when they come to see you in clinic may not align with the sex marker on their record. If in doubt, ask. I think it's easier to ask a few too many people and have them be a bit confused sometimes than miss asking someone. There are various ways to support transition on the NHS records before the process of legal transitions taking place. So options include a known as name, a change of title, including high priority reminders for pronouns, which I think is a System 1 thing, apologies. And then at a later point, there is also help with the gender reassignment request. So prefixes can be changed on System 1 fairly straightforwardly. Change of gender marker on the NHS record is something that, when we've been discussing this session, I know is something we've been talking about. So it previously involved submitting this gender reassignment request, and you as the GP not diagnosing someone as with gender dysphoria, not saying that someone is trans, but simply that they wish to have their gender marker changed and they don't at this point intend to change it back in the future. That used to involve a new NHS number being generated because gender is encoded into NHS numbers. And there are some implications, therefore their notes need to be transferred over, and there are implications for screening programs, which we will come back to. It is the person's the legal change of name lies with the responsibility of the patient. So they will do this standardly via a deed poll. The system in the UK is that a deed poll is essentially something that you print off the internet, you write on it, and 2 of your friends sign it. It's not that official compared to some other countries. And then you make 1 million copies of that and send that out to every business, bank, everywhere. What is most helpful in that admin process, if you also wish to change your gender marker at the same time, is a letter from the GP, where there's standard wording available on the Gov.uk website, and I think we've included it in the resource pack, that allows the change of gender marker to go along with that. And then that allows you to change your gender marker and your name at the same time on either your passport or driving licence. Again, that's not asking you as a GP to diagnose anything. Because once you've got either a passport or a driving licence changed, it makes everything else a lot simpler. And something that's talked about a lot in the media, in things like that, is the gender recognition certificate. That's way later and doesn't involve GPs. So the gender recognition certificate only affects birth certificates, death certificates, and marriage certificates. It does require specialist confirmation of diagnosis, but that's not a GP letter. So just rest assured that if you're doing this, it's not actually anything to do with that, if that is a concern for people. So, as we discussed, screening. So at the moment, the national screening programmes are based on the automatic triggers are based on the recorded record of gender. Different screening depends what screening you need as a trans person, depends on what body parts you have. So cervical screening, any patients who have a cervix. So this will include some trans men who haven't had hysterectomy. This won't include trans women. I suspect, because of the age ranges that is captured by cervical screening, they have the easiest way to re-register this. So they have an opt-in form, that's a link for when the slides are sent out, which the GP can fill in having discussed with the patient. Breast screening is eligible for any trans men who still have breast tissue that can be screened with a mammogram, or any patients who've been on estrogenizing hormones for over 2 years and are otherwise eligible. So for trans women who have changed their gender marker, they will already automatically be picked up by this, but there may be situations where people aren't that. If someone isn't automatically going to be picked up, the patients can ask GPs to request a referral, or they can contact the local breast screening services directly themselves to register. And then lastly, AAA screening is the only one which is purely based on birth sex. So anyone who's assigned male at birth is eligible for AAA screening, and therefore if trans women have changed their NHS number and won't be picked up by that, again, they can contact the screening service directly, or there are other ways that GPs can also help with that. And in terms of this, high priority reminders are useful and scheduled tasks, I'm informed by my colleagues, but there can be risks of human error. I hope that in the future, as the population grows, these opt-in forms will become more common. And the other thing we've brought to today's session is, along with that survey, we asked people in the local community who I've worked with in a couple different volunteer situations. We asked them for some quotes about how their care has been managed. So I won't read all of these out, but just I think an example of how this confusion about documentation can cause effects for patients. So someone told us, the practice manager told me I needed a gender recognition certificate to update my name, not just a deed poll. A preferred name has been added, but this can only be used after security is completed, so all calls start by asking for my dead name, and some receptionists continue to use that throughout conversations. But also people have reported that they're very grateful, they've got shared care, they wish some communication was better, it's confusing and stressful when the GP and endocrinologist give contradicting information or don't match what's in the shared care agreement. So I'd like to move on now to talk a little bit about gender-affirming hormone therapy. So gender-affirming hormone therapy is the administered prescription of cross-sex hormones in many cases in order to create a secondary sex characteristics and external appearance aligning to that of the felt gender. So as a thought experiment, if I'd only had my first assessment at Porterbrook, if I'd gone through the NHS system, I would have had that first assessment. I would still be waiting for all of the rest of my care. For the last 4 years of working in hospitals in my foundation year, I wouldn't have presented, no one to look at me would know to use he, him pronouns or to treat me like a man, or that my name made sense. And just thinking about how many patients we all meet every day, the struggle to introduce yourself and constantly advocate, it's clear to me that my ability to function and therefore my mental health, my ability to contribute to society is all massively positively impacted by the fact I've been able to access care 5 years earlier than I would have on the NHS. And the study and the literature backs that up. So the studies quoted here are meta-analyses and systematic reviews. And they've shown that gender-affirming hormone therapy improves quality of life, it decreases depression and anxiety, and it decreases suicidality. There is improved social and global functioning with these treatments, and longitudinal studies have shown that not only do the symptoms of depression and anxiety improve throughout the prescription of gender-affirming care, but physiologically cortisol levels have also seen to improve. And that's backed up by, when I went to Porterbrook and I was chatting to them, they said, well, we basically see two types of patients now. We see people like you who are economically stable and have been able to afford private care, and it's all a bit of a box ticking exercise. And then we see the people who haven't been able to afford that care, and they've become introverted, they've developed worsening mental health outcomes, snowballing comorbidities through this time. And I do genuinely think that this is, and the evidence also shows that there are health inequalities actively forming due to this. And something that's also talked about and we wanted to touch on is regret rates, because I know that regret and detransition are a concern to us when we're thinking about gender-affirming hormone care. So the surgical regret rate for gender-affirming surgery is around 2%. Sounds a bit risky, but if you compare that to bariatric surgery, it's 20%. Hernia repair is 11%. Cancer-related prostatectomy, 30% of people regret. And just for fun, 31% for marriage and 13% for kids. So if we're not sending people for 2 psychiatric evaluations before they have kids, which has a 6-time higher regret rate, you know, something to think about. And so we've got another quote here from another person. When I moved house last, I was rejected from several GPs before I found one that would take me. My limited access to a helpful GP restricts my movement and my ability to change jobs. And what we've got here next is a video from another of the MedAct contributors also talking about
Hello, my name is
life.
Catherine. I'm a Sheffield-based trans woman, and I just want to talk a little bit about my experience of accessing transition-related care and the positive interventions that GPs have made. I first started experiencing gender dysphoria when I was 15, and I first approached my GP asking for a referral to a GIC in October 2018. It took me a number of tries. The first GP I spoke to said, if you're having these feelings, come back in a month's time and we'll talk about it again. I still had those feelings, same response again, come back in a month's time. And I think it took until January 2019 for this referral to be processed and accepted by the GIC. And it shouldn't require so much work on the part of the trans patient. So please make those referrals when the patients approach you for them. I was already expecting a long wait. The waiting time was expected to be 2 years, which is quite a painful thing in itself. Transition-related care is a time-sensitive intervention. The longer it takes for a trans person to receive HRT, the harder it is to undo the changes that testosterone and estrogen are going to make to you. So the fact it takes so long is a real point of pain for the trans community in the UK at the moment. And when it came to about 2021, the 2 years had passed and gone, and all indications were saying that it was going to be even longer before I got an appointment with the GIC. So I approached my GP, basically desperately asking for help. I was lucky enough to get an appointment with Dr. Prosser, who referred me to, at the time it was Dr. Peter Hammond at the Harrogate Gender Clinic for bridging prescriptions. And 10 months later, I had my appointment with Dr. Hammond, and it was a really, really respectful, an hour-long discussion, which was focused on my wants and expectations of HRT, and very shortly after, I received my full transition-related prescriptions. So I cannot emphasize enough how life-saving that intervention was for me. I also received, as a result of the intervention of Dr. Prosser, fertility preservation treatment on the NHS, which again, I'm extremely, extremely grateful to. So I would really, really recommend that you refer your trans patients for bridging prescriptions. I eventually got my first GIC appointment in May 2024. The process is essentially you have an initial appointment with a nurse, followed by an appointment with a clinical psychologist to assess whether you have gender dysphoria. I received great, very respectful treatment from the staff at Porterbrook Clinic, but the interviews were very invasive. These were 3-hour-long interviews, which covered a huge amount of personal information, my hobbies, my sexual history and interests, my career, my entire life story basically, and the notes of these are on my medical records. And I frequently frequently have to beg GPs not to look at these because they're very personal. So again, I would please bear in mind that there may be personal information on medical records that trans people might not necessarily want you to view. Additionally as well, something I want to touch on is trans broken arm syndrome. Often trans people experience GPs assuming that unrelated medical issues are as a result of their transition. I experienced a particularly bad case of this where I mentioned having migraine once to a GP, and that resulted in my target levels for my estrogen to be dropped, and that caused me a lot of difficulty because essentially I was experiencing low estrogen levels, and I found it very, very hard to get these taken seriously. It was causing mood swings, it was causing hot flashes, it was causing menopausal symptoms basically, and it took a very long time. It took essentially waiting until I got my GIC appointment with an endocrinologist there, which was about 7 years after I initially approached my GP back in 2018 to get that finally resolved. So yeah, please don't assume that every medical issue is a result of transition-related care. Thank you very much. Wish I could be there in person, and thanks for listening. Bye-bye.
Great. So I'm not going to spend... Is that still working? I'm not going to spend too much time going over barriers to care and also providing care, because we appreciate that funding is a massive issue for you guys especially, and that these are not always easy problems to deal with. And there are also concerns over medical legal complications. So what I also wanted to touch on is systems both internationally and in the UK for access to gender-affirming healthcare. So what we've discussed so far is the medical model, wherein there are psychiatric evaluations, there is diagnosis of gender dysphoria, and you essentially, you as a person, present your evidence to a clinician, who then provides access to treatment. What is becoming more common internationally is the informed consent model, wherein essentially these moments are taken out. This works on the assumptions of bodily autonomy, that no one's doing this for fun. Despite what some people think, I'm not taking testosterone to be a bit stronger or faster. I've made those decisions, and neither of those psychiatric evaluations particularly helped firm them up. That was me going to a doctor to convince them of what I knew. So the informed consent model involves discussion between the clinician and the person who has already come to this decision, saying, do you understand these hormones? How are these going to alleviate your gender care? And therefore, through a slightly less paternalistic method, initiate treatment. That's becoming more common in Europe. It's very common in the US, although insurance providers often ask for these psychiatric evaluations, and it's becoming more discussed. So the WPATH guidance do discuss it as a way of moving forwards and an appropriate methodology, obviously on a case-by-case basis. That's going to work for some people who don't have a lot of comorbidities. It's going to be a less optimal solution for others. And then the other method of accessing gender-affirming healthcare is what is colloquially known as DIY. So this is sourcing hormones off the grey market and administering themselves. Again, timing, wishing, we will come back to that to discuss it a bit more. And then there's the methods in the UK. So we've discussed the private shared care a lot already today. So that's where the patient pays privately for their gender assessment, and then in combination between the private provider and the GP, bloods are ordered, interpreted, and prescriptions are written. Sorry, pointing at the wrong one. There's also the GIC system, which is kind of the NHS-funded one, where the gender assessment is carried out by the GIC. Blood interpretation is shared between the GP and the GIC, depending on the local agreements, and bloods are ordered by the GP and prescriptions done by the GP. For some patients who aren't able to access or find a GP that will agree to private shared care, they may consider going fully private. However, there are significant costs associated with that. Prescription charges and blood tests are expensive. And then there's also what we're going to talk about next, which is GP-led bridging prescriptions. Now, I know these are talked about a lot, both within the community and for GPs. So this is where, as a initially created as a harm reduction measure because of the knowledge of these waiting lists and these issues in accessing care. NHS, and it was discussed that bridging prescriptions will be created where no official diagnosis of gender dysphoria is given. However, to reduce harm to the patient, a GP may initiate hormones, prescribe them and order bloods, and interpret the bloods either on their own or, in some cases, with the assistance of an NHS endocrinologist. So, as discussed, this was set up as a harm reduction measure back in the days when we stuck to the NHS constitution saying that patients should wait no longer than 18 weeks from GP referral to treatment. I know that's not the case for most conditions now. And so the risks and the harm that is most discussed about being reduced here is those whose mental health is being affected by their lack of access to care, or those who are DIYing and putting their health at risk. There's sort of a feeling within the community, if I just may for a second, that essentially here you're paying for your treatment with your time, which may be 10 years. Here you're paying with money, and if you're DIYing, you're paying with a chance to your health. So bridging prescriptions are the fastest route for trans patients to access hormone treatment on the NHS, and medical legally, you are backed for them. So the Royal College of GPs say that GPs may initiate hormone prescriptions. The GMC reassures doctors that wish to prescribe bridging prescriptions without assessment at GSE, that it's not against GMC guidance. However, it doesn't require doctors who don't feel they wish to, that they have to. So it's a bit waffly, the GMC guidance. And medical legally, sort of if uncertain about indemnity cover, then the best advice is to contact a defence union. But given the context of everything we talked about, trans health organisations do strongly encourage GPs to prescribe bridging prescriptions where they feel able to. So, what on here have we discussed? And what's important to remember is that this is not the GP saying that they are competent to diagnose gender dysphoria. This is a GP creating a harm reduction measure where they say to the patient, you have to understand that I'm not the specialist in this. Are you happy to accept the treatment on the basis? So it's essentially following that informed consent model that is more common the world over, but we're having difficulty accessing. The guidance we've quoted, the GMC and RCGP guidance, also mentions that doctors should be able to seek specialist advice if unconfident. We've got some resources about that later on. The Porterbrook openly accessible online guidance is really good, and they also have an urgent advice number. Urgent is they'll get back to you in 48 hours, but still. And I won't go through this too much because I need to hand over to Hannah. But I also just wanted to sort of demystify these prescriptions a little bit, because actually estrogen counselling is something that I think GPs do all the time. I'm assuming that everyone here has prescribed HRT for postmenopausal women, and contraception, and many of the side effects in the counselling is essentially identical. The risks are of VTE. There is and changes to infertility, which can be discussed with a patient. The effects are as written, and just to note, the only permanent effect is breast growth. So everything that's not in italics would change were the HRT to stop. And something that's also discussed is change in risk status. This is just to say that although quoted that HRT increases your risk of breast cancer, headaches and migraines, that's simply because a population who is assigned male at birth has a lower risk of those things naturally, and so your personal risk increases, but not above population averages, simply to the population average of the population you're joining, if that makes sense. And similarly for testosterone counselling, Again, the only permanent changes are in italics, so increased body and facial hair, and clitoral growth. And the changes in risk status are similarly moving to the testosterone-driven hormone system, so lipid profile and personal cardiovascular risk increases. The main side effect of testosterone to be aware of is polycythemia. This is dose dependent. There's a lot of guidelines about how to manage that. And yeah, I just wanted to give a little bit more context for DIY before I hand over to Hannah. So the community who access hormones on a DIY basis is a broad spectrum. I know some of you may have had contact with these people already. For some people, it's about being in control of their own hormones and their own bodies, and they're probably quite happy doing that. But I'm aware that within the city, and more commonly, there are people who are just simply unable to access hormones any other way. They don't have the money for a private avenue, and so they feel they are turning to this cheaper situation, and they would love some advice and guidance. They would love to access hormones any other way, and those harm reduction measures can be really helpful there if they can be considered. And yes, so there's a range of motivations there, and there's a range of reasons that people may be considering this. So thinking about how to support patients who are using DIY hormones, something to consider that accessing blood tests is the most difficult and expensive part of it. So, and particularly the blood tests that are difficult to access are the safety monitoring ones. So whilst for various reasons you can get at Meadowhall a hormone profile panel for about £40, and you can monitor your hormone levels that way, an FBC or an LFT will each individually cost you £50 or £60. So patients doing this may be motivated to monitor and able to monitor their hormone levels, but they're then pick and choosing which safety effects to look for. So it's just something to think about is, even if you're not able to do any other harm reduction measures, are you able to provide some information and open a conversation with someone and get some safety bloods for them? And one last quote from someone in the community saying, I've been on DIY hormones for a year, I've taken private blood tests, but I've not told my GP about this, as I don't have confidence I'll get support, and I worry that this would negatively impact any other healthcare I receive. So I'm going to hand over to Hannah.
Hello. Thank you very much, Otto. That was really, really interesting and really helpful. I'm conscious it's late in the afternoon, so we'll try and get through the next few slides really quickly. I'm Dr. Hannah Prosser. I'm the medical director and I'm the GP lead for transgender patients at the University Health Service. So we look after the students of the University of Sheffield. I am not a GPSI, I'm not working in secondary care, I don't have a consultant supervising my prescribing decisions, and I'm not initiating AMBER medication. I'm just working as a normal GP in primary care like a lot of you all are. But over the years since I took on this role, around 8 years ago when I joined the practice and I was the first transgender lead GP, I've just sort of gained some insights and some helpful things that I'm going to share with you today that you'll hopefully find helpful. So when I first started, we had a handful of trans patients, and over the last 8 years that has grown massively. When I checked this morning, it's actually 290. So our prevalence rate compared to the 0.5 that Otto mentioned is closer to 0.9. So we do see a lot more transgender patients than maybe you all are. Given our patient demographic, I am only talking today about over 18s. If there is an appetite to talk about under 18 trans healthcare, that might be for another afternoon. And so over the last 8 years, we as a practice have upskilled, not just myself, I'm not the only GP, we all see transgender patients, we're all involved in their care. Our nursing team are involved in all of the injections, and there are certain injections that we can now teach our patients to do at home. Our admin team, in terms of the secretarial team and the reception team, helping with the name changes. And we're lucky to have a data quality team who help with recalls, so we have separate recall systems for trans men who need cervical screening and abdominal ultrasound if they've been on T for more than 5 years. And they also help out with people wanting to change their gender, and we have a consent form, and I'll talk a bit more about that later. So it's really been a collective in that we as a practice noticed this unmet need and worked all together to kind of upskill in this area. There is a lot of training out there available. There's an RCGP, there's lots of places that do e-learning modules. There is an organisation called Pride in Practice it's accredited by the Royal College of GPs, by the Royal College of Nurses, by the Royal College of Dentists. They've come to our practice, done an audit, done some in-house training. So there's lots of places where you can upskill. I'm very happy to meet and talk with anyone after this. And we've also got an idea of how collectively we can come together as a city at the end to kind of help and support each other to give some consistent health support to this demographic. What I like about this area of medicine, and the only reason I agreed to do this one this afternoon, is that it's just an area of medicine I feel really passionately about. This is an underserved demographic, and they are all incredible patients. They've often been through an extremely difficult time. They might have been completely ostracised by their family, by the people that are supposed to love and unconditionally accept and support them. And I see the way that they interact as a community and help and support each other. And people have found new families here in Sheffield in their community. So we've talked a bit already. I'll race through some of these slides because Otto's covered this so excellently, but just in terms of for practices at the moment who are not prescribing and who are not interested in prescribing, there's loads of non-drug interactions you can do that would be gender affirming. So it's really important. One of the things we did was have a PPG just of our transgender patients, and a lot of the feedback was not about drugs, it was about not being misgendered when they registered. It was about using the tannoy system, could it please be the name that they want, because then everyone looks at them and sees a name that doesn't match how they're presenting. It's having some signage up in your waiting room, some rainbow signage or something that shows that you're an inclusive practice. And it's making sure that the right information goes in the medical notes and mimicking what the patient is telling you, what they like to, how they describe their gender expression and the pronouns and name that they like to use. We can all offer to take a history, we can all offer to refer them to an NHS GIC, and by taking a good history you can then just copy and paste it into your referral, so that saves you some time. And depending on your interest and how much time you had, and maybe you can't do all in one appointment, maybe you're bringing them back, but just being in any way validating that they've probably been through a really difficult time. How has this all impacted on your mental health? I'm really glad that you've come in to talk to me about this today. Let's see what we can do to help you in your journey going forward. For some people, they'll have a really clear idea what it is that they want. They want hormones yesterday, or they're still questioning, but they know the waiting lists are long, so they want to get a referral in early. And it might be the part of their dysphoria that's particularly triggering that they want help with. So for a trans man, it might be their periods and you can offer a depot or a pop. It might be that they really want surgery. Unfortunately, they still have to go through the whole pathway to get to the surgical interventions. I think it's a great opportunity. They might have had these conversations with their families, with their place of work, and had a really either awkward or negative experience of coming out. And if you're someone who is positive and affirming and validating and say, I'm glad you've come in to talk to us about this, then that's like a small thing that we can all do that doesn't cost any money. Oh, there's a few things not to do as well. This has been some feedback and some things I've learned in training over the years. So in terms of the NHS pathways, yes, the waiting time in Sheffield is really long. When I first started, it was the shortest in the country. It's now one of the longer ones. So at the moment, we refer most of our patients to Nottingham because it's a 2 to 3 year wait for a first appointment there. And if you offer patients, you'd have to get a train to Nottingham or wait 5 extra years to be seen in Sheffield. Most of them are happy to go to Nottingham, and Nottingham will accept referrals from Sheffield GPs. None of the GICs are commissioned to prescribe, so it's not a traditional shared care prescribing where they're up titrated to an effective dose and then it's passed back to a GP. We are asked and expected to do the prescriptions from the get-go, so that's important to know if you are referring to an NHS GIC. I know that this is an underfunded area. There is a LES, which, so in Sheffield you will get money if you do prescribe, if you do the monitoring bloods for NHS GIC patients. There's lots of areas where the NHS doesn't quite stretch, and over the years primary care is asked to do more and more. I'm sure you've all seen increasing burdens, especially in things like mental health. Again, if it's one thing you can do to agree to refer and agree to do the bloods, then that's brilliant. So in the video, Kath mentioned a NHS bridging prescription clinic with Dr. Hammond, who was an endocrinologist in Harrogate. Unfortunately, he retired from NHS practice. So at the moment, I only know of one consultant endocrinologist called Dr. Leong. He works in Arrow Park Hospital, so it's on the Wirral. He's happy to accept referrals from GPs all over the country. He just likes, well, he needs, the referral criteria is that the patient has had one diagnostic assessment of gender incongruence. So realistically, at the moment, that is a private assessment. If you've had your first appointment at an NHS GIC, often they don't share that as a diagnostic assessment until they've had the second and the MDT discussion. So yes, so as a GP, I'll talk about Dr. Leong, and I end up saying something along the lines of, as an NHS doctor, I absolutely hate having to signpost anyone to the private sector. As we've discussed already, there's massive health inequalities. For some people, it's just not an option. But I say, well, if there's any way that you can afford the private prescription, we can then get you into this clinic with a consultant endocrinologist who's experienced, qualified, very patient-focused, who knows exactly what he's talking about. At the moment, there's a 6-month wait for his clinic, so it's not nothing, but it's much, much better than the alternatives. And his letters come back, they're pages long, there's a full diagnostic assessment. He's happy to be one of the gender recognition certificate doctors, and then he writes back with a full shared care protocol. He likes to meet the patients face-to-face for the first appointment, but after that he's happy to do remote telephone video consultations, and he would need you to do the blood test, otherwise the patient would have to travel back to the Wirral every time they need blood test. So in terms of private clinics, this is a big minefield, and I know this was some of the feedback, was how do we know the quality and the validity of the private clinics? Because at the moment there's no accreditation system, anyone can call themselves a private gender specialist. So we, in conjunction with our colleagues at Porterbrook Medical Centre, who look after the Sheffield Hallam students, Dr. Terry Hudson is there, transgender lead GP. He did have to leave, but we very much copied a due diligence checklist that they had created. And I don't know if my laptop has stayed alive. Where is that? Oh, so if we could maybe plug it in now. So we're one of the, oh sorry,
Sorry, just whilst we're waiting for the laptop, if there's a red Toyota Yaris MV20 ZKM, apparently you're blocking someone in. Just whilst we're doing the tech stuff.
So we're one of the 2 practices in the world still using EMIS Web, so, but there is a System 1 equivalent that they use at Porterbrook. This is a template that Nat, who's in our data quality team, built for us, because she's amazing. So there's lots of different, this is a dummy patient. There's 6 different tabs down the side. The first one we use for a basic history taking, which helps either GPs who are not as confident about their history taking, or just all the prompts that will come up on the referral criteria when you fill out either do a referral. There are some questions that come up like forensic history, so making sure you've asked those. Then there's just a thing here about, if we go to the next tab please, Nat, so initial medication history. So we found we were saying the same thing to a lot of patients, so we've just got it in a standardised way that we actually don't do bridging prescriptions. I don't know if we will eventually, but at the moment we don't. So the things that we say every time to each patient we would just have put into this template. In terms of the shared care checklist, so this is what we do in terms of due diligence. So if it's an NHS GIC, we would always say yes to that, and that would include Dr. Leong's clinic. If not, we're looking to see, are they based in the UK? We all know of a certain clinic that is no longer based in the UK anymore. Ideally, that it's an MDT approach, that there's at least one medical professional, because there are some nurse-led or pharmacy-led clinics, no disrespect, but the GMC guidelines suggest that there should be one medically qualified who's worked in gender dysphoria for more than 2 years. And if they fulfill all of that criteria, then we say yes. So again, that just gives consistency in terms of who we're saying yes to. When it comes, there's also a couple of tabs here about just reminders about the monitoring blood. So of the 290 patients, we have about 120 who we're doing monitoring bloods for, and of those, about 100 we're doing a shared care, either with a private or with Dr. Leong or with an NHS GIC. And then a tab here about change of gender. So if someone comes in for a change of gender discussion, it's quite easy for the clinician. They open up this tab and they can read through it, and then we send, and we've got an Accurix template ready to go with the consent form for patients to sign, and a link to the gov.uk guidelines, which are actually quite good, on screening for trans and non-binary patients, and then just some links at the end. So for anyone who's an EMIS practice who would like us to share that, then yeah, please let me know. If you are a System 1 practice and you'd like that, then again, please let me know and I can link you up with Dr. Hudson. If we could go back to the presentation. So yeah, if you're a practice who doesn't feel happy about prescribing, do you feel you could do at least the monitoring bloods and ask the patient to send them to their private clinic if they don't have an nhs.net email address that you feel happy to send them to? Oh, the clicker has stopped working. I think we're nearly there. Oh, lovely, great, thank you. So if we do get a shared care request from our private clinic that we don't feel happy to do shared care with, we say, look, we're happy to do the bloods, and you can continue to get your medication privately from this clinic, or we can refer you to Dr. Long's clinic because you've had your private assessment. We're also happy to do, as a practice, we made the decision that if patients are doing DIY, we are happy to do blood tests, including hormone levels. By agreeing to blood tests, you're not making a comment on if they do or don't have a diagnosis. You're not prescribing for them, and by including the hormone levels, these patients are incredibly well informed, and I've not met anyone DIYing who did it in an irresponsible way. But obviously that's the conversation for you guys to have as your own practice. Gaming cryopreservation, so until December of last year we could refer on the NHS for any patient, whether they were self-medicating private clinics. The ICB have since unfortunately pulled that funding, so now you can refer to Jessop's. They will do, so there's a lady called Deborah in Andology, or Mr. Skull in the Jessop's wing, and the trans patients we've had going through that process have commented that it's been a very positive and trans-inclusive experience, but now, yes, they need to have been seen by the NHS GIC. Monitoring, so like I said, there are people in your practice that you might be able to help in terms of the admin of it, in terms of contraception. There's really good advice from the faculty. There's no limitations really. A lot of trans men don't want estrogen, so they don't want the combined pill, but there's no interaction with their medication. Laser hair speech therapy and surgery. So again, these are all possible once you've been seen in the NHS GIC, so that's another reason why we really encourage everyone to get onto an NHS GIC waiting list. So following this, I have been in touch with Dr. Leong. I said, are you happy if I tell them about your clinic because you might get an onslaught of referrals? He was like, yes, that's great, please get them all to refer. I'm very happy to see them. We spoke to Dr. De Bono, who's the endocrinologist who supports the Porterbrook NHS GIC, and he's happy that if we formed a coalition of GPs who want to join a WhatsApp group, if there's any, obviously we can't make comments on prescribing, but if there were queries, we can escalate them to Porterbrook, and if there's anything they can't answer, then they would escalate them to Dr. De Bono. And hopefully there'll be things that maybe some of us see day in, day out that for other people is a real headache, and it might just be a really easy place to find out some information about primary care for trans patients. I think that is our final slide. Yes, so there's, like I said, a lot of resources for patients who you are thinking about bridging prescriptions. The Leeds NHS GIC has tons of information on their website about doing that safely, what to tell patients, what to talk to them about. It's really, really detailed. Porterbrook are always really happy, keen, interested to have people go down and visit them. So if you had some CPD hours you wanted, you could take some study leave and go and spend the morning or an afternoon sitting in a clinic or going to the MDT. That's something I did and found it incredibly helpful. The team there are all really brilliant. I think that's everything. So, thank you all very much.
I'm just going to say again, please do join this WhatsApp group. It will mean that if you've got any doubt and you're wanting to help someone but you're not really sure on something, you can then ask other people and get some support and feel a little bit more confident in it. The link for that will also be circulated in the resource pack. It's now going to be time for Q&A, I think.
Hi, with regard to fertility preserving treatment, does that have to be started or considered before HRT is started or not?
It depends a little bit. So you can't do fertility treatment whilst on HRT, but you can do pauses and still have success, but it can be a little bit variable. So if it can be done before, that's the best chance of success, but it's absolutely possible to just pause HRT and do the preservation.
Yeah, just recently, the feedback we're getting from STH if we refer is that they want trans men to have stopped testosterone and for their cycles to have been resumed before referring, because that can be, for some people, very short, for some people a longer time. That can obviously be a really distressing thing to have to ask a patient to do. In terms of the andrology, again, I think it's 6 weeks of not being on estrogen before they would accept a patient, and even then it might, but yeah, ideally best done before.
Hi, thanks. Can I just clarify that Waterbrook are happy to provide support to GPs doing bridging who are not on their waiting list? Because I've previously had a non-Sheffield GIC say they wouldn't support a bridging prescription and they wouldn't give me advice.
So I'm not sure what the official word is from Waterbrook, but whenever I've messaged them about a patient who's on their waiting list, the reply is often quite quick, like a week or two, and it says that we haven't seen this patient yet, so their diagnosis hasn't been confirmed, but if they were our patient, this is how we would reply to your question. So it's, yeah, they really do try to be helpful. That's my experience with them, yeah.
Hello, Dr. Leong, sorry, I just don't quite understand. So he's an NHS consultant, is he?
Yes.
So you'd be referring them
By
NHS.
ERS
Okay.
to Arrow Park Hospital, general endocrinology.
But they'd have to have a one private assessment first, okay, and then he would send a sort of shared care. And is that not quite the same as bridging? That's just more like a normal shared care.
Well, it's, yeah, good point. It's bridging them between where they are now and when the NHS GIC picks them up. So he's not going to see them forever. He can't refer them for surgery or laser hair or psychology or any of those things. But from a medical perspective, it's trying to mimic or be as close to the gold standard as possible.
My other question, my pharmacist wanted me to ask. So we haven't currently got our transgender patients on a sort of recall system because we find, obviously at first it's sort of 3 monthly and then it's 6 monthly and then it might be annual. So have you got any tips about how to set up a good recall system?
Yes, well, Nat in our data quality team kind of led on this, so she might be better, but we found a code, because we don't do a lot of HRT and postmenopausal women, so we found a code somewhere that she uses to search for that, and then followed, we add a certain code, and that's the start date, and then we can see if it's 3 or 6 or 12 months from there. I don't know if that helps, but yeah, if you come and find me later, I can try and find that code for you.
Yeah, I was just going to say one thing with Dr. Leong is that, so that one-off thing is £400, £500 depending on the clinic, but then you don't have any ongoing, for the psychiatric diagnosis, and then you don't have the ongoing, so it's a lot more manageable to sort of know that you just have to pay once and then you'll be on the NHS rather than not knowing how long you're going to have to continue paying for private appointments.
Can I just check again about the Waterbrook advice, because I've definitely asked about whether they could advise on patients who were under private shared care, and they said they couldn't. It wasn't Dr. De Bono, but I asked at a PLI when this was discussed last time. So can they advise us about patients who are...
So this is someone who's been initiated in the private sector, but is no longer able to see the private sector, for example?
Yeah.
I don't know, because that would be someone I would just refer to Dr. Leong, for example, because they've had one assessment, and if it's an endocrinology advice you want about side effects or switching or abnormal blood tests, maybe I've been lucky the couple of occasions, and it is less and less now because we do use Dr. Leong so much, but the couple of occasions I have had quite helpful replies back, but maybe it's just how they felt on the day. I've definitely not had a blanket no comment. There's usually the first letter saying, we'll aim to get back to you, we're very busy at the moment, and then a reply's come a couple of weeks later. I'm sure officially they can't, you can understand if they say officially we can't comment on meds that weren't initiated by us on a patient that we've never met. I think that's a reasonable stance for them to have. But if it's been something quite specific, then I find them to be quite helpful. Yeah.
Given that question's been asked a couple of times, when we send the resource pack out, we'll see if we can get the answer from Waterbook themselves to share with everyone.
Do you have international patients that come in that might be on a regime that they've started that you might not be au fait with, and how do you practically handle that?
So in the university setting, yeah, definitely. Although worldwide, there's really only 2 medications, estrogen, testosterone, and then the blockers, so 3, I guess. So it's very similar. I guess the difficulty is how, I guess that would be someone that we would either refer to Dr. Leong because they've got an established diagnosis from someone back home, and then the 6 months if they've immediately run out as soon as they arrive. I think, yeah, we would ask them to try and get some shipped out. Oh, yeah, it's really difficult. But the trans patients that come internationally are nowhere near as complicated as, say, the mental health patients who come overseas on all sorts of strong medication combinations for very mild mental health problems.
Thank you.
I think we've got one more at the back.
Hi, did you say that the GICs are non-prescribers? What exactly did you mean by that? What implications for us?
Sorry.
As in they're not commissioned to prescribe, they don't issue any prescriptions, they don't issue any FP10s, they don't have a pharmacy at the clinic. So after the patient's had their first appointment, they get their diagnostic confirmation, they're like, right, you'll be started on these medications, but it's your GP that's going to have to physically issue that first prescription. Yeah. So it's not a traditional shared care, say for something in secondary care where the dose is up titrated to a stable level and then passed back to the GP at that point. So it's just an additional ask, which is just, it is how it is, and unfortunately with that, obviously it's down to the commissioning, but that's where we are with trans NHS clinics at the moment, yeah.
Hi. One thing you mentioned earlier was about the act of providing bridging prescriptions in advance of, essentially in advance of an assessment. The model you gave us, it sounds like the guidance was conceived in the aim for a target of 18 weeks, which is not a huge amount of time to be providing medications off-label. Now we're waiting lists between 5, 10, sometimes more years. That's a long time for GPs to essentially be prescribing something with very little input and holding all the medical legal responsibilities. I appreciate these things are, they are life-changing, very beneficial, but on the flip side, a patient therefore developing a VT and potentially coming to harm as a result of that treatment is a very difficult prospect for a GP to hold. And I wonder what your thoughts might be, given that it seems that the waiting lists are unfortunately not coming down anytime soon, or any people think.
Yeah. I mean, I ended up, when I was doing the practice, I ended up on some research ethic papers, and yeah, it's a classic beneficent versus non-maleficence. I appreciate I'm not a prescriber, so I'm not taking that medical legal responsibility, but the evidence does show that, you know, further complications are created by waiting for hormones, and that health harms do come with those, whereas the VTE risks are not high. And, you know, hopefully in the future, like, we've got all of these tools for contraception things, which are like HRT tablets for post-menopause. That's the same medication that is used. So you would hope that there will be further improvements in the guidance for that. Medical legally, I know we've discussed with Hannah that you said that actually the Medical Legal Defence Union was quite positive about providing bridging prescriptions, and that that's a risk that they feel was manageable. But yeah, obviously it's not ideal for anyone, the current situation, but it's just trying to protect patients and work with them and respect their autonomy and balance all the classic medical ethics as best we all can.
I just want to add, so this feels a bit vulnerable saying in a big room like this. So I, a few years ago, started bridging a prescription for somebody who, as a harm reduction approach, and I don't know if other people in the room did it, but it felt really vulnerable. And I did loads and loads of reading. I read GMC guidance, I read all the guidance, I went and spoke to the MDU, who were actually really surprisingly positive about it, and said, this is a clinical decision, you're supported by all the kind of organisations to do this if you think that it's in the best interest of this patient. And we wrote a contract with the patient, which probably wouldn't stand up in court, but we went through all the things you said, so they understood that I wasn't an expert. And there's a few things that feel really vulnerable because we are not, we have to act within a competency and we are very much on the edge. So that phrase that you highlighted is a really difficult one to overcome. And the fact that it says that you have to have specialist advice, and as I just said, the organisation said they wouldn't provide specialist advice, and so it's felt a really vulnerable process. Having said that, the patient is doing well and is on the list for GIC, and I'm hoping that the next couple of years we'll get seen, but it has felt really vulnerable, so I really understand that question coming from the floor, because we might be doing it for years, and that's a really hard thing. But then, hearing your experience and having seen the experience of other people, it is such a difficult thing for anyone to be living through. I just can't even imagine what that would be like. But yes, there are a few of us out there doing it. I only do it for one patient, but it does feel really vulnerable.
Well, thank you, everybody. I think that we have dried up in terms of questions there. Just want to say a really big thank you to the team here who have delivered the PLI events, both the trans healthcare event and the diabetes update. Many thanks. I think probably both deserve a huge round of applause. So thank you all for attending today. We'd be really grateful if everyone could submit feedback based on the event today. You can do so by scanning the QR code. We will be sending slides and resource packs out to everyone, so please do watch out for those in the updates. And thank you once again.
Well done, guys. Thank you. I don't want to come without you.
I know what you were doing. Yeah, I had loads of things on. Golf on a pre-course.